Hello everyone, my name is Oluwawemi Modej, and today I'll be presenting a comprehensive assessment of a child case study. The case I selected focuses on attention deficit hyperactive disorder, and I chose the combined type. Over the next few minutes, I'm going to walk you through the patient's history, exam findings, differential diagnosis, diagnostic skills, and evidence-based plan of care. My goal is to highlight how a structured psychiatric evaluation aligns with DSM-5 criteria and clinical guidelines. My patient, J.M., and I use these initials just for confidentiality purpose, is a 10-year-old boy in 5th grade. Information was gathered from both his mom and teacher, along with his medical record. His mother's main concern, and his teachers as well, is that he cannot sit still and rarely finishes his schoolwork. This clear functional complaint is what brought him for evaluation. I'm going to talk about his history of present illness. His symptoms began at age 6, and over the last 2 years, they've become increasingly disruptive. His inattention presents as forgetting homework, losing items, and difficulty sustaining focus. His hyperactive and impulsive behaviors include constant fidgeting, interrupting his peers, and leaving his seat during class. Importantly, these symptoms occur in both home and school environments, this tells us that impairment is cross-situational, which is a key factor in ADHD diagnosis. Moving on to his medical, surgical, and mental health history. Medically, JM has a history of asthma and allergies. He has never had surgery. Psychiatrically, he has no prior diagnosis and he has never been in therapy. His family history is notable. His father had ADHD and his maternal aunt struggles with depression. This highlights the genetic loading for both attentional and mood disorders. Concerning his medication history, currently JM uses albuterol as needed for asthma, and he uses loratadine daily for allergies. He has not been prescribed any psychotropic medications. Since he has not been on antipsychotics, we do not need to apply the AIMS scale, which is used to monitor for tardive dyskinesia. Let's talk about his developmental and birth history. JM was born full-term through uncomplicated vaginal delivery. He weighed 7 pounds and 6 ounces. His developmental milestones were age appropriate, walking by 14 months, his first weight by 13 months, and toilet training by 3 years. He was toilet trained by 3 years. There have been no regressions or developmental delays, which help us rule out broader neurodevelopmental disorders. Talking about his social and family history, JM lives with both parents and a younger sister in a supportive home environment. There are no reports of abuse or neglect. At school, his grades have been declining, although he does not yet have an IEP or 504 plan. Socially, he enjoys playing soccer. But his distractibility often affects his participation and relationships with teammates. No substance use is reported. It is important that I tell you that this review of systems is most notable for psychiatric symptoms of inattention, hyperactivity, and impulsivity. Sorry, I can never say that word right. Neurologically, there are no seizures or headaches. Gastrointestinally, appetite is normal. Sleep is somewhat impaired. It takes him nearly an hour to fall asleep at night. His asthma is well controlled and there are no other systemic concerns. On physical exam, JHEM's vitals and growth charts are within normal limits. His neurological exam is non-focal. On mental status exam, he appears restless and interrupts frequently. His mood is okay, with congruent affect. His thoughts process is linear, and there are no hallucinations or delusions. Importantly, his attention and concentration are impaired, which is consistent with his presenting complaints. So the Vanderbilt Parent Rating Scale was administered. JM scored 7 out of 9 on inattentive symptoms and 8 out of 9 on hyperactive impulsive symptoms. Its scores confirm impairments in both academic and social domains. These results strongly support its diagnosis of ADHD or the combined type of ADHD. In my differential diagnosis, I considered oppositional defiance disorder, since disruptive behaviors can overlap. However, JHEM does not exhibit persistent anger or defiance towards authority. I also considered an anxiety disorder, as restlessness and inattention can occur with anxiety, but JHEM does not demonstrate excessive worry or somatic complaints. ADHD combined type remains the most consistent diagnosis given JM's history and the symptoms and scale results. So considering JM's history, symptoms, and its scale results, I believe ADHD, the combined type, is the most consistent diagnosis. JM meets DSM-5 TR criteria for ADHD, the combined type. He has more than 6 inattentive and more than 6 hyperactive impulsive symptoms, persistent for over 6 months. Symptoms began before age 12 and present in at least 2 settings and cause significant functional impairment. His case is therefore a clear and valid diagnosis of ADHD combined presentation. So treatment begins with a multimodal approach. Pharmacologically, methylphenidate, the extended release, which is a Ritalin, the extended release, 18 milligrams daily, is recommended as first-line therapy per AAP and AACAP guidelines. Non-pharmacologic supports include cognitive behavioral therapy for coping skills, parent training in behavior management, and school accommodations such as a 504 plan. Baseline growth, vitals, and appetite should be monitored every 3 months. Follow-up is scheduled in 4 weeks or sooner if adverse effects occur. This plan aligns with evidence-based best practices. That completes my presentation. I can finally present you the scholarly sources that guided my case analysis, including the DSM-5 TR, the American Academy of Pediatrics Clinical Practice Guidelines, and a recent review in the Journal of Child Psychology and Psychiatry on ADHD medication management. This ensures the recommendations are grounded in current evidence-based practice. Thank you so much for listening. I hope you have a nice day.